Welcome to the Code Internist, where we decode medicine, one concept at a time. I'm Dr. Pejy Arce C. Casem, a licensed physician, diplomate, and fellow of the Philippine College of Physicians. I also hold a master's degree in information systems and am currently pursuing a doctorate in information technology. As both an internist and innovator, I believe in harnessing the power of technology to make complex medical concepts easier to understand. In today's episode, we're diving deep into diabetes mellitus. Not just what it is, but how it's diagnosed, classified, and how it affects the body at a cellular and systemic level. This disease is widespread, and understanding it is vital not just for future doctors, but also for anyone working in healthcare. Let's begin with what diabetes mellitus really is. It's not just one disease, but actually a group of metabolic disorders that all have one thing in common: hyperglycemia, or high blood sugar levels. This condition isn't caused by a single factor. It arises from a combination of genetic predisposition and environmental triggers. In simple terms, the body either doesn't produce enough insulin, can't use it properly, or the liver makes too much glucose. Any of these can lead to persistently high blood sugar. Hyperglycemia doesn't just stay in the blood, it slowly damages almost every organ system in the body. It's the leading cause of kidney failure, blindness in adults, and non-traumatic amputations, especially in the lower limbs. But the biggest threat? Cardiovascular disease. Heart attacks and strokes are far more common in people with diabetes, and these are the top reasons for death in this population. Diabetes mellitus isn't just divided into type 1 and type 2. That's the classic way we classify it, but there are actually other forms, especially now that we better understand the genetics behind the disease. These include monogenic types where a single gene is responsible, and atypical cases that don't fit neatly into type 1 or type 2, but may have characteristics of both. Still, type 1 and type 2 remain the major categories, and that's where we'll focus first. In type 1 diabetes, the body's immune system mistakenly attacks the insulin-producing beta cells in the pancreas. As a result, the person can no longer make enough insulin. That's why we call it absolute insulin deficiency. Type 2 diabetes is more complex. It usually starts with insulin resistance, where the body's cells don't respond well to insulin. Then over time, the pancreas can't keep up, leading to reduced insulin secretion. On top of that, the liver releases too much glucose. All these contribute to high blood sugar levels. Before a person is officially diagnosed with diabetes, there's a silent period where blood sugar levels are starting to go up, but not yet enough to be called diabetes. In type 2 diabetes, this stage is known as prediabetes. It's marked by either impaired fasting glucose or impaired glucose tolerance, basically early signs that the body is struggling to maintain normal glucose levels. This is a critical time for intervention because lifestyle changes can still make a big difference here. Recent research has given us a better way to understand how type 1 diabetes develops. It's now divided into 3 stages. The first stage starts when autoantibodies appear, meaning the immune system has started attacking the pancreas, but blood sugar is still normal. In stage 2, sugar control starts to break down, and by stage 3, diabetes becomes clinically obvious with high blood glucose levels. While type 1 and type 2 are the most common, there are many other less common causes of diabetes. Some people have genetic mutations that affect insulin production or how insulin works. Others may have metabolic or mitochondrial issues that interfere with the normal regulation of blood sugar. These are important to recognize because they might not follow the usual patterns of type 1 or type 2 diabetes and could appear much earlier or behave differently. A specific form of genetic diabetes is monogenic diabetes, caused by a single gene defect. One type of this is MODY, or maturity-onset diabetes of the young. It runs in families in a dominant pattern, meaning one parent can pass it on. It usually shows up before age 25 and is due to problems with how insulin is released. It's not the typical autoimmune or resistance-type diabetes. That's why it needs special attention. Sometimes, diabetes results from damage to the pancreas, like in cystic fibrosis or chronic pancreatitis. These damage the part of the pancreas that produces insulin. In other cases, hormonal imbalances can interfere with insulin's action. For example, in conditions like Cushing's disease or acromegaly, the body produces too many hormones that block insulin, leading to high blood sugar. Though very rare, some cases of diabetes can happen after a viral infection that damages the insulin-producing cells of the pancreas. A dramatic and sudden version of this is called fulminant diabetes. It's been observed in Japan and is believed to start quickly after a viral infection. This form doesn't follow the slow progression we see in usual type 1 diabetes. Gestational diabetes develops during the second or third trimester of pregnancy. It happens because pregnancy itself causes the body to become more resistant to insulin. When the body can't keep up with insulin demands, blood sugar levels rise. If a woman is found to have diabetes in the first trimester, it's no longer considered gestational diabetes. Instead, it's classified as pregestational diabetes, which means the diabetes existed before pregnancy, but was only discovered during early prenatal care. After giving birth, most women with GDM will see their blood sugar levels go back to normal. But that's not the end of the story. There's still a 35 to 60% chance of developing type 2 diabetes in the next 10 to 20 years. Even their children aren't spared. Babies born to mothers with GDM have a higher chance of developing metabolic syndrome and type 2 diabetes when they grow older. That's why the ADA now recommends lifelong diabetes screening every 3 years for women who had GDM. There are unusual forms of diabetes that don't clearly fall into type 1 or type 2. These are called atypical diabetes. They aren't caused by single gene mutations like MODY, but they behave in unpredictable ways. For example, some very lean individuals, or even children before puberty, may show signs of type 2 diabetes. Others may suddenly present with diabetic ketoacidosis, but later on, they don't need insulin therapy. These patterns are especially noted in people of Asian or African ancestry. Diabetes mellitus is officially divided into 4 main categories. First, type 1 diabetes, where the immune system destroys the beta cells in the pancreas, leading to almost zero insulin production. Second, type 2 diabetes, which involves insulin resistance and a gradual decline in insulin secretion. The third category includes other specific types, often due to genetic or secondary causes. And finally, we have gestational diabetes, which is specific to pregnancy. Some forms of diabetes are due to mutations in specific genes that affect beta cell development or function. These fall under monogenic diabetes, such as MODY. The most common mutations occur in genes like HNF1 alpha, HNF4 alpha, and glucokinase. In rare cases, mutations in mitochondrial DNA or the insulin gene can cause diabetes in infants, either as a permanent or transient form. There are also rare cases where diabetes is due to defects in insulin action, as seen in syndromes like leprechaunism or lipodystrophy. Certain hormonal diseases like Cushing's or acromegaly can also cause hyperglycemia. Additionally, drugs such as steroids, antipsychotics, or HIV meds may induce diabetes. Even infections like rubella or Coxsackie virus can be culprits, though rare. Some rare syndromes are associated with diabetes due to immune dysfunction, like in stiff person syndrome or anti-insulin receptor antibodies. There are also genetic syndromes that carry a higher risk of diabetes, such as Down syndrome, Turner's, Klinefelter's, and Wolfram syndrome. These cases are less common, but important to recognize, especially in pediatric or developmental cases. Diabetes has grown from a few million in the 1980s to hundreds of millions today. From just 30 million in 1985, we now have over 460 million people living with diabetes worldwide, and by 2040, it's expected to reach over 640 million. Type 2 diabetes is increasing the fastest, largely due to modern lifestyle changes like poor diet, inactivity, and aging populations. Type 1 diabetes is also rising, but not as quickly, although it's now being seen in younger children more often. In terms of absolute numbers, the highest number of diabetics live in China, India, and the United States. In the U.S., diabetes affects about 10.5% of the entire population. That's around 1 in every 10 Americans. But it gets more concerning with age. By age 65, 1 in 4 Americans has diabetes. Even more worrisome, 1 in 3 adults already has prediabetes, often without knowing it. Diabetes doesn't affect every region or group equally. Scandinavian countries have the highest rates of type 1, while type 2 is most common in the Pacific Islands and Middle East. In the U.S., minorities are disproportionately affected. American Indians and Alaska Natives have the highest rates, while even Asian Americans, despite having lower BMI, still have significant risk, often developing diabetes earlier and at younger ages. In Asia, diabetes tends to strike younger and at a lower body weight compared to Western populations. That's because Asians are more prone to store fat viscerally around the organs, which is more harmful than fat under the skin. Also, their bodies tend to produce less insulin, making them more vulnerable even at lower weights. Diabetes isn't just a medical issue, it's a global emergency. In 2019 alone, 4.2 million people died from diabetes-related causes. That's over 1 in 10 adult deaths worldwide. Economically, the burden is staggering. $760 billion are spent on diabetes care worldwide. Most of those affected, around 75%, live in low and middle-income countries, where healthcare resources are already limited. Blood sugar control is grouped into 3 categories: normal, impaired, and diabetic. We use 3 main tests to measure it: fasting plasma glucose, oral glucose tolerance test, and HbA1c. If your values are below the cutoff, you're considered normal. If you're in the middle range, that's called prediabetes, which means you're at risk. Once your blood sugar is consistently elevated above the thresholds, you're considered diabetic. Prediabetes is the stage where the body's glucose regulation is no longer normal, but not yet diabetic. You might hear the terms IFG, IGT, or HbA1c 5.7 to 6.4%. These are early warning signs. People in this category are at high risk, not just for developing type 2 diabetes, but also for heart disease. This is the time where lifestyle changes can really make a difference. You only need one positive result: FPG, OGTT, or HbA1c, above the cutoffs to meet the diagnostic criteria for diabetes. Or, if your blood sugar is high and you have the classic symptoms like frequent urination, excessive thirst, or weight loss, that's enough too. Among these tests, FPG and HbA1c are most commonly used for routine screening because they're easier and more convenient. While HbA1c is convenient, it may be affected by ethnicity. For example, African Americans tend to have slightly higher HbA1c levels, even with the same actual blood sugar as whites. The OGTT is still valid, but mostly reserved for pregnancy. If the person has no symptoms, we usually repeat the test to confirm. But if someone has classic symptoms plus very high sugar, we don't need to wait. We can diagnose right away. To sum it up, we diagnose diabetes using FPG, HbA1c, OGTT, or random glucose. Any one of them crossing the threshold is enough. If the patient doesn't show symptoms, we double-check with a repeat test. Catching diabetes early, especially in prediabetes, gives us the chance to intervene and possibly prevent full-blown disease and complications. Screening is crucial because most people with type 2 diabetes don't even know they have it. In fact, it can be present for up to 10 years before being diagnosed. And by that time, complications like eye, kidney, or nerve damage may already be there. Starting treatment early not only helps control blood sugar, but can actually change the course of the disease. Also, finding prediabetes early gives us a chance to prevent diabetes altogether. The American Diabetes Association, ADA, recommends that everyone aged 45 and above be screened for diabetes at least once every 3 years. But for people who are overweight or obese, screening should be done earlier, especially if they have even just one risk factor like high blood pressure, family history, or sedentary lifestyle. There are many risk factors that call for early screening. These include family history, certain ethnic groups, and medical conditions like high blood pressure, high cholesterol, and PCOS. Skin changes like acanthosis nigricans, which looks like dark patches in the neck or armpits, are also clues. If a person is inactive or has signs of insulin resistance, screening becomes even more essential. Certain groups need more frequent screening. If you've already been told you have impaired glucose or prediabetes, yearly checks are advised. Women who had gestational diabetes should be screened every 3 years, and people living with HIV should also undergo regular screening due to their elevated risk. Glucose homeostasis, or sugar balance, is the result of three key processes: what we eat, what the liver produces, and what the tissues use up. The hormone insulin is the master regulator, helping manage this entire system. But it doesn't act alone. The body also uses glucagon, nerve signals, and other metabolic factors to fine-tune everything. Think of it as a team effort. Insulin keeps sugar down after meals, glucagon keeps sugar up during fasting, and both respond to the body's needs throughout the day. When you're fasting, insulin levels go down and glucagon rises slightly. This signals the liver to make more glucose by breaking down stored glycogen or creating it from amino acids and fats. This is gluconeogenesis. At the same time, muscles and fat tissues reduce their glucose use, and the body starts using fat stores and protein breakdown to keep energy flowing, even when no food is coming in. After eating, the body switches gears. Insulin levels rise, and glucagon drops. This tells the body to start storing energy. Muscles absorb more glucose to make glycogen. Fat cells store more fat, and protein synthesis is activated. Insulin plays the role of a builder after a meal, storing sugar, building proteins, and preparing the body for the next fasting period. It's not just insulin and glucagon calling the shots. Other body tissues send messages too. Fat cells release adipokines, muscles send myokines, and even bones release hormones that affect how well the body uses sugar. This network of chemical messengers helps the organs talk to each other to keep blood sugar balanced and energy flowing efficiently. Insulin production begins inside the beta cells of the pancreas. It starts as a big, inactive protein called preproinsulin, which gets trimmed down to proinsulin. From there, it's further processed into the active hormone insulin, along with a companion molecule called C-peptide. The insulin molecule has two chains, the A and B chains, linked together by disulfide bonds. Both insulin and C-peptide are stored and released together when needed. C-peptide is more than just a leftover piece. It's released at the same time as insulin and stays in the blood longer, making it a useful marker to measure how much natural insulin the body is making. Doctors use it to figure out if someone is making their own insulin or if the insulin is coming from injections, especially in cases of unexplained low blood sugar. Another molecule released by beta cells is amylin, also called IPP. It's secreted alongside insulin, but its exact role is still being studied. What we do know is that amylin builds up in the pancreas of people with type 2 diabetes, forming amyloid deposits. Synthetic versions of amylin are even used as adjunct therapy for both type 1 and type 2 diabetes in some cases. Glucose is the primary trigger that tells the beta cells to release insulin, specifically when blood sugar goes above 70 milligrams per deciliter. But it's not the only one. Amino acids, ketones, certain gut hormones, and even nerve signals can also boost insulin secretion. This means insulin response is not just about sugar. It's about how the entire body reacts to a meal or a stress signal. Let's break down how glucose triggers insulin release. First, glucose enters the beta cell through a specific transporter. Then, it's processed by glucokinase, which is the critical gatekeeper step. As the glucose gets metabolized, ADP increases, which leads to the closing of potassium channels. This changes the cell's electrical state, causing calcium to flow in, and that's what actually triggers insulin release. Insulin is released in two phases. The first is a quick burst of stored insulin. This helps manage the sugar spike right after eating. The second is a slower, sustained release, important for longer-term glucose control. In both type 1 and type 2 diabetes, one of the earliest problems is the loss of that first phase insulin response, which leads to post-meal sugar spikes. Incretins are hormones like GLP-1 and GIP that are released after eating. They help increase insulin secretion, but only when blood sugar is already elevated, and they also suppress glucagon, which helps prevent the liver from making too much sugar. Medications like GLP-1 analogs and DPP-4 inhibitors mimic or enhance these hormones and are now widely used in type 2 diabetes treatment. We used to think GLP-1 only came from the gut, specifically the L cells after eating. But new studies show it can also be made right in the pancreatic islets, especially by alpha cells. This local production may help fine-tune how insulin is secreted, offering an exciting look at how the pancreas may regulate itself. After being released by the pancreas, insulin first travels to the liver through the portal vein. There, it helps stop the liver from making more glucose and promotes sugar uptake by the liver cells. But here's the catch. Half of the insulin is cleared right away by the liver. Only the remaining insulin reaches the rest of the body. This difference is important when we give insulin injections, because injected insulin goes straight to the body, not the liver first. Once insulin reaches the body's cells, it binds to the insulin receptor on surfaces like muscle or fat cells. This binding triggers a series of events, starting with tyrosine kinase activity. The receptor activates itself through autophosphorylation and pulls in helper molecules called IRS, or insulin receptor substrates. These are the messengers that carry insulin's instructions deep into the cell. One of insulin's most important effects is through the PI3 kinase pathway, which tells the cell to bring GLUT4 transporters to the surface. These are the gates that let glucose in. But insulin does more than just manage sugar. It also promotes glycogen storage, builds proteins, and encourages fat storage, making it a true anabolic or building hormone. To summarize, insulin's first stop is the liver, where it tells it to stop making sugar and start using sugar. Then, insulin works on muscle and fat, helping them take in glucose through GLUT4 and store energy in the form of glycogen, protein, and fat. Insulin's job is to keep sugar levels in check by telling your body where to store or use it. Type 1 diabetes happens when the body's own immune system attacks and destroys the beta cells in the pancreas, the ones that make insulin. This destruction is triggered by a combination of genetic tendencies, environmental exposures, and immune reactions. Eventually, when enough beta cells are lost, the body can't produce insulin anymore, leading to high blood sugar and full-blown diabetes. Type 1 diabetes progresses through stages. In stage 1, people already have 2 or more beta cell autoantibodies, but their blood sugar is still normal. In stage 2, glucose levels start to become abnormal. Stage 3 is when symptoms appear and the diagnosis is made. Sometimes, the shift to diabetes happens faster, especially after infections or during puberty, when insulin needs naturally rise. After diagnosis, some patients enter a honeymoon phase, a short period where their blood sugar is easier to control, and they may need less insulin or none at all. But this doesn't last forever. Eventually, the few remaining beta cells wear out, and insulin production completely stops. Interestingly, small numbers of beta cells can still be found decades later, even in long-time diabetics. Type 1 diabetes is strongly influenced by genetics, but not entirely. Even identical twins only both develop the disease 30 to 70% of the time, which means other non-genetic factors are also involved. The biggest genetic contributor is the HLA region on chromosome 6, which helps start immune responses. Variants here account for half of the inherited risk for type 1 DM. Most children with type 1 diabetes carry specific HLA haplotypes, especially DR3 and DR4, and more specifically DQA1 and DQB1 variants. These genetic markers are seen in about 40% of kids with type 1 DM, compared to just 2% of those without it. Interestingly, there are also protective genes, like DQB10602, that make developing type 1 DM extremely rare. Aside from HLA, more than 60 other genes have been linked to type 1 diabetes risk. These include the insulin gene itself, as well as genes that regulate immune balance like CTLA4 and IL-2 receptor. By combining these into a genetic risk score, researchers can better predict who is at risk. But remember, genes aren't destiny. Many with high-risk genes never develop the disease. Even if someone has a relative with type 1 diabetes, the risk is still fairly low, about 1 to 9% for children of a diabetic parent, and 6 to 7% for siblings. Surprisingly, over 90% of people with type 1 diabetes have no family history at all. That's why we say, genetics increase risk, but they don't guarantee you'll get the disease. Type 1 diabetes is mainly driven by an autoimmune attack on the insulin-producing beta cells of the pancreas. A hallmark of this process is insulitis, a mild infiltration of immune cells into the pancreatic islets. While islets sell autoantibodies, ICAs, are key biomarkers. They don't destroy the cells directly. Instead, CD8 positive T cells are the main killers, releasing toxic substances and triggering inflammation that damages beta cells. Islet cell autoantibodies, or ICAs, are directed at specific targets like GAD, insulin, and others. They're present in over 85% of people at the time of type 1 diabetes diagnosis. Having 2 or more ICAs is now considered the first stage of the disease, even before blood sugar levels become abnormal. ICAs can also predict who's at high risk, especially in children with strong genetic predisposition. Beta cells don't just sit passively. In some cases, they may unintentionally make themselves targets by displaying neoantigens or overexpressing MHC class I molecules, which attract even more immune attacks. Then, CD8 positive T cells, inflammatory cytokines, and oxidative stress work together to kill the beta cells, leading to full insulin deficiency. Because it's hard to stop type 1 diabetes after diagnosis, research now focuses on early intervention, even before full-blown diabetes sets in. One breakthrough is teplizumab, an anti-CD3 antibody. A short course of this drug in stage 2 diabetes has been shown to delay the onset of clinical diabetes by nearly 3 years. While beta cells are the main targets, other islet cells like alpha and delta cells are spared, but they don't work the same. Their hormone release becomes abnormal, worsening the blood sugar instability. What starts the immune attack? We still don't know for sure, but suspected triggers include viruses, milk proteins, low vitamin D, toxins, and even changes in the gut microbiome. In type 2 diabetes, there are 2 key problems. The body becomes resistant to insulin, and over time, the pancreas can't produce enough insulin to keep up. Most people develop insulin resistance first. This means the insulin they have doesn't work well anymore. The pancreas tries to compensate by making more insulin, but eventually, beta cells get exhausted. That's when blood sugar goes up, leading to diabetes. Type 2 diabetes isn't a single disease. It's more like a spectrum of disorders that all lead to high blood sugar. Each person may have a different combination of insulin resistance and beta cell dysfunction, and this variation depends on genetics, lifestyle, and even ethnic background. Research shows that type 2 diabetes differs among ethnic groups. For example, Latinos often show strong insulin resistance. East and South Asians tend to develop diabetes younger and at a lower body weight, often due to early beta cell failure. Meanwhile, African Americans may experience severe complications like hyperosmolar crisis without going into ketoacidosis. Aside from genetics and biology, social factors also play a major role in type 2 diabetes. This includes things like poverty, poor diet, limited access to healthcare, and chronic stress. Even if 2 people have the same genes, these social determinants can cause very different outcomes. Genetics play a powerful role in type 2 diabetes. When both parents have type 2 diabetes, there's a high chance the child will develop it too. Even those who are not diabetic but are first-degree relatives of patients often show early signs of insulin resistance, like reduced glucose use in muscles. But it's not just genes. Lifestyle and environment also matter. What you inherit is one thing, but how you live and grow also matters. Families often share the same lifestyle, diet, activity, and even stress levels, which influence diabetes risk. Even before birth, if the mother has high blood sugar during pregnancy, the baby's future risk of diabetes goes up. Surprisingly, both low and high birth weights are linked to higher chances of diabetes later in life. Scientists have found hundreds of genes linked to type 2 diabetes, but most only slightly increase the risk. One important gene is TCF7L2, which affects how insulin is produced and released. Others affect how the cells in the pancreas function or how signals are sent for insulin release. But none of these can fully predict who will get diabetes. Even though we've discovered many genes, they only explain less than 10% of the total risk. Right now, genetic testing can't accurately predict who will get type 2 diabetes, but research is moving fast. For now, lifestyle choices remain the most powerful factor we can control. Type 2 diabetes isn't just about high blood sugar. At its core, It involves multiple systems breaking down their usual balance, like reduced insulin release, the body's cells not responding well to insulin, and the liver producing too much glucose. There's also abnormal fat metabolism and chronic low-level inflammation happening quietly in the background, making the disease more complicated and systemic. Obesity, especially central or belly fat, is a strong driver of type 2 diabetes. Around 80% of patients with T2DM are overweight or obese. The fat stored around the organs worsens insulin resistance. But early on, the body tries to fight back. The pancreas releases more insulin to keep blood sugar levels normal. This is the compensation phase. As insulin resistance worsens, the beta cells get overwhelmed. They can no longer produce enough insulin to meet the demand. This shows up as impaired glucose tolerance, where blood sugar rises after meals. Later, insulin drops further, glucagon rises, and the liver floods the bloodstream with more glucose, leading to fasting hyperglycemia and a full diagnosis of type 2 diabetes. Insulin resistance means that insulin can't work properly on key target organs, especially the muscles, liver, and fat. This is a defining feature of type 2 diabetes. It's caused by a mix of genetics, obesity, and chronic inflammation in the body. Because of this, the body needs more insulin than normal to achieve the same effect. And even then, glucose use is significantly reduced, by up to 60% in some cases. Insulin resistance hits two areas hard. First, it causes the liver to release more glucose, especially at rest, which leads to fasting hyperglycemia. Second, it limits glucose uptake in muscles after meals, causing post-meal blood sugar spikes. Glucagon also plays a role by further pushing the liver to produce more glucose. The real trouble happens after insulin binds to its receptor, what we call post-receptor defects. Inside the cells, something's off with how the signals are passed along. Muscle cells get filled with fatty molecules, damaging their energy factories, the mitochondria, and producing harmful free radicals, which trigger inflammation and worsen insulin resistance. Fat isn't just storage. It's an active organ that releases chemicals called adipokines. These include inflammatory substances like IL-6 and TNF-alpha, which mess with insulin sensitivity. The problem worsens in visceral fat, which drains straight to the liver, flooding it with free fatty acids. This disrupts liver function, encourages glucose overproduction, and damages beta cells too. In type 2 diabetes, the pancreas tries to keep up with insulin resistance by releasing more insulin. But over time, the quality of insulin response starts to fade, especially after eating. The very first insulin spike after glucose is blunted, and even if the pancreas still responds to other triggers like arginine, it can't maintain this for long. By the time someone is diagnosed with type 2 diabetes, their beta cell function may already be down by 50%. A clue to this is the increase in proinsulin, a less active form of insulin. Over time, beta cells accumulate amyloid deposits from a substance called amylin, which might worsen or reflect ongoing damage. What makes beta cell function worse over time? It's a toxic environment. Constant high blood sugar damages beta cells in a process called glucotoxicity. Too many fatty acids in the blood, lipotoxicity, and inflammation from immune cells in the pancreas also contribute to cell burnout. The good news? If we lower blood sugar early, we can sometimes recover some beta cell activity. One major problem in type 2 diabetes is the liver's failure to respond properly to insulin. Even though insulin levels are high, the liver keeps making sugar, a process called gluconeogenesis. This causes fasting blood sugar to rise and prevents the liver from storing sugar properly after meals, contributing to poor glucose control. Because fat cells also become insulin resistant, they release more free fatty acids into the bloodstream. These fatty acids go to the liver, which converts them into triglycerides and packages them as VLDL. This lipid overload leads to the classic dyslipidemia of type 2 diabetes: high triglycerides, low HDL, and harmful small LDL. When the liver becomes overwhelmed by fat, the extra lipids accumulate inside the liver cells, leading to fatty liver or NAFLD. This can cause abnormal liver enzymes in labs, and over time, might progress to more serious liver problems like inflammation or even scarring. Insulin resistance doesn't just cause diabetes. It is part of a larger cluster of conditions that often occur together, called metabolic syndrome. This includes high blood sugar, high blood pressure, bad cholesterol patterns, and central obesity. These all work together to greatly increase the risk of heart disease and type 2 diabetes. There are also rare but severe forms of insulin resistance. In type A, young women show signs of high insulin, obesity, and hormonal symptoms. In type B, it's more common in older women and involves autoimmune attacks on insulin receptors, which can sometimes even cause episodes of low blood sugar due to overstimulation. PCOS is a common condition among women before menopause. It causes irregular periods, acne, and excess hair due to high male hormones. Many women with PCOS have insulin resistance, which greatly raises their risk for type 2 diabetes, even if they are not obese. In some rare conditions called lipodystrophies, people lose fat in specific parts of the body. This leads to severe insulin resistance and high blood triglycerides because the body can't store fat properly, and fat ends up in places like the liver and muscles instead. Not all diabetes is type 1 or type 2. Some are caused by single gene mutations, called monogenic diabetes or MODY. These often run in families and may look like type 1, but don't always need insulin. For example, MODY3 responds well to sulfonylureas. MODY2 doesn't even need treatment. But MODY5 is more severe and may involve other organs like the kidneys or liver. Some babies are diagnosed with diabetes even before 6 months old. This is likely neonatal diabetes, not type 1. It's genetic and can be either temporary or permanent. In some cases, just giving oral sulfonylurea meds instead of insulin works, especially when caused by potassium ADP channel mutations. Others may have missing pancreas, hearing loss, or misfolded insulin. We should think of monogenic diabetes when we see patients with very early onset diabetes, especially before 6 months of age, or when the clinical picture doesn't fit type 1 or 2. A strong family history, no obesity, or unexpected good response to tablets instead of insulin. These are clues. These patients deserve genetic testing to guide better treatment. Type 2 diabetes is mainly caused by two problems. The body doesn't respond well to insulin resistance, and the pancreas can't make enough of it. Most people with this condition have high blood sugar levels, and many are overweight or have metabolic issues. Depending on ethnicity, some people may develop it earlier and at a lower BMI. In the beginning, the pancreas works extra hard to make up for insulin resistance. Eventually, it wears out, leading to both high post-meal and fasting blood sugar. The liver also adds to the problem by making more sugar. Obesity and inflammation only make things worse. The muscles don't take in sugar well, the liver makes too much, and the fat tissue releases too many fatty acids. These changes mess with insulin's job. On top of that, chemicals from fat cells cause inflammation, worsening insulin resistance and cholesterol problems. At first, the pancreas loses the quick first shot of insulin. Later, it just can't keep up. More immature insulin, proinsulin, gets secreted. Long-term high blood sugar and high fat levels damage the beta cells even more. Type 2 DM often runs in families. Some rare forms like MODY or neonatal diabetes are genetic and can be treated differently. If a patient is young, thin, or doesn't behave like typical type 1 or 2 DM, we should suspect a gene issue and consider testing. Thank you for joining us in decoding type 2 diabetes, its diagnosis, classification, and pathophysiology. Let's keep learning together. Don't forget to subscribe to the Code Internist for more easy-to-understand, high-yield videos on medicine and health.